I'm going to blind you with a few bits of data. You can see in this graph, this is opioid overdose deaths in the US, how it's grown since 2001, and how particularly you see that blue on the last year in 2014 is rising fast, and that really is to do with the oncoming of fentanyl. Fentanyl, as you saw in the video, 50 times as strong as heroin. There's also there's a relation between prescription drugs and these overdoses. Interestingly enough, Massachusetts, you see, so this shows 5 little pill boxes, right? Massachusetts is not actually in one of the most prolific states in terms of prescriptions, and even Florida is. And Florida is in that same box on the left-hand side, and that reflects the fact that things like fentanyl are now very often not coming from prescriptions, but are being manufactured in drug labs. But it is a very eastern side of the U.S. Phenomenon. So you can see New Hampshire, Massachusetts, and also Florida and Ohio being the main states where this happens. I just want to, the mayor already mentioned some numbers, just for you to get it in perspective, really. So 1 out of 140 Americans is addicted. That's 1.9 million. To opioid, this is. So this is not alcohol, this is not anything else, opioid. 1 out of 75 Americans uses opioids recreationally, at least once a month, at least once in the last month. So this is a large number. 1 out of 60 Americans have used at some point in their life, and 1 out of 20 of Americans uses prescription painkillers that were not prescribed to them. So they either use prescriptions from their spouse or some other way. And 1 in 15 of people taking non-medical painkillers, meaning not having been prescribed them, ends up taking heroin within 10 years. So it's the gateway to the heroin addiction after that. 4 out of 5 heroin users started with painkillers. Average age of first opioid painkiller use, 21. So these are people getting a Percocet for having a wisdom tooth extracted. These are people maybe having had a sports injury, in some cases recreational use, but that's the average age. Average age of first heroin use, 28 years. So there's a relatively long period in the average in between there. 15 billion a year is what pharmaceutical companies in the US generate in revenue for opioid drugs. And 55 billion is the estimated cost to American society as a result of it. So now we're talking overdose deaths, 140 a day in the US every day. And just for comparison, so traffic fatalities, 105 a day. So this is now, bar alcohol, this is the single biggest accidental cause of death in the US. And gun-related deaths, just wherever you stand in the gun debate, it's a heavily debated issue, actually represents only a quarter of the number of deaths daily that opioid overdoses do. So that's how serious this issue is. 12% of Americans needing opioid-related treatment are getting it, and I think that's a challenge that we need to deal with. How do we get that percentage further up? 28,000 opioid-related overdoses in 2014. That's the last available data on US-wide. And 50% of those were prescription opioid overdoses. But there's good news too. There's a new act in Massachusetts, and you just saw about that. People having had an overdose, 91% being prescribed another set of opioids. So the new Massachusetts law limits painkiller prescription to a 7-day supply, meaning you have to actually go back and see a doctor to get more if needed. And there's a whole host of measures, but for example, registration of opioid prescriptions. You can, if you had problems before with an opioid addiction, have your medical records altered so that it says do not prescribe. Of course, you have to go through recovery first before you make that decision, so quite how effective that is, I'm not entirely sure yet. And training guidelines for medical professionals on the overprescription. It also sets a 24-hour evaluation requirement for overdose victims in the ED, and we'll come back to that later. Because there's some real practical issues around that. Because of course people don't want to stay in the ED, especially when they're back on their feet. Schools to verbally screen students for drug use, and also expand addiction education programs. We'll come back to that too. Just a little bit more data. Please bear with me. Massachusetts, so we're going to slowly drill down to Lynn. Massachusetts, just under 1,400 overdose deaths last year, 11% increase. Number 2 in the US in fentanyl seizures, and that's the same here in Lynn. 76% male and 24% female. That's a lot more females than was originally the case with heroin addictions, and 85% white. And you can see where it's most prolific, right? North Shore, South Shore, Cape Cod. Those are the areas. This is no longer an inner city, big inner city problem. Then to Lynn. We said 1,379 overdose deaths in Massachusetts, and the top 5 cities in Massachusetts account for a quarter of that. You heard the mayor say 50, and that is 50 is the correct number. This is a state-reported number. It says 41 for Lynn, and that's because a lot of the detox reports take longer to come back, and so the number has slowly been edging up. Even now it still is. But you can see Lynn is number 5 on that list, and actually if you project it over population, Lynn is number 3 on the list in Massachusetts. 4.4 deaths per 10,000 inhabitants. You're going a little quick. 1 a day overdose in Lynn on average, but yesterday there were 3. So there's days without, and there's days where there's 3 or 4, and 1 fatality a week. That was the case last year. That's still the case in the first 6 months of this year. So the good news, if you like, is that the growth is tailing off. Where over the last 3-4 years it had been growing quite prolifically. It seems to have stemmed at this level for the time being. 71% of those overdoses received Narcan, and that's up 10% from last year, and that's something to do with the reduced number of fatalities. 65% are Lynn residents. So Lynn is a market, essentially, for these products. People come from towns outside Lynn, very often use while they're in Lynn. They'll probably drive the car just around the corner and use it there. But still, 2/3 are Lynn residents. 72% white, non-Hispanic, and 20% Hispanic. So the population that's affected by this is very different from the population that was affected, for example, by the crack cocaine crisis 20 years ago. And also very interesting is the age spread of the overdoses and the fatalities you see in that graph. So the picture many people appear to have is that this is something that happens to young kids, 18 to 21. They're actually the least represented group in the overdose category. So the biggest group is 31 to 40, and that's concerning because a lot of those people are parents, so they have children. And then there's also actually recently some in the 51 plus, and very often those are people who've been using drugs for a prolonged period of time and have reduced physical fitness. What works? So data, there's now data is being collected, and largely it's based on data from the police department that is then shared with other people to inform policy, and is driven by police and health providers. The police reports forms the basis. Bridgewell collates it, and then there's also data collection by others, so hospitals, the coroner's department. But it does need further integration. The data now reports on what has happened in the past. It doesn't yet inform actions necessarily that could go towards the future in an organized and centralized, coordinated way. And that's something that we want one of the work groups to work on in a minute. So I've got a few questions here. How can data inform policy? Because now comes the question, how do we change the way we work in Lynn based on the things we know? If certain things happen at certain addresses, what do we do with those addresses? If we know that there are a number of overdoses at a particular location, which happens to be a sober house, what do we do then to make sure we don't get overdose number 8, 9, and 10 at the same location? So some of these questions will come back in one of the work groups that is going to deal with data. There's also another challenge, and that's the data on an individual level. Both the law enforcement community and the health provision community have all kinds of guidelines of what they can and cannot share. And actually on the health side, it's probably even stricter, which makes it very hard for those two communities to work together on how we deal with individual cases once they've had an overdose. And one of the questions, again, in one of those work groups is how could we somehow overcome that? How could we design a process in which those privacy regulations do not form a barrier for creating a good chain of cooperation? And how can we slowly edge people towards the right programs and the right approach? There was once a task force to deal with overdose repeaters, And the reason that it hasn't continued successfully is really because of this data sharing issue. So that's something we really need to sort out, and that's one of the outcomes that we would like to work on after this event. And then can the coalition, so the coalition we'll come back to later, Marianne O'Connor will speak to that, but there is now a coalition in which law enforcement, health providers, city government take part. Can they become the driving force in that? That's what we're looking for. We want to just show you something basic on what happens when a 911 call gets made. Just we don't know how many overdoses really happen. The ones that we have are the ones that are reported. I guess it's just like a regular crime statistic. You have to make an estimation of how many overdoses happen that we don't know about. But when 911 does get called, police, fire, and ambulance all go. It's on a priority number 1. Dispatcher stays on the call with whoever made the call. The Samaritan regulation means that whoever made that call, even if they were a user themselves, can't be arrested at that particular time for the life-saving that they're doing. Every first responder carries Narcan, so not just the ambulance. The police has Narcan in the cars, but the fire department has Narcan in the cars, and whoever's there first tends to administer that. But the police tends to be first because they have patrol cars driving around, right? They don't have to come from a particular location. EMS has an 8-minute maximum response time, but I understand that within Lynn, usually that's less, and it's around 5 minutes. 5 or 6? I'm sorry, 5 or 6. So then the patient gets stabilized and then transported to the ED. If the patient is prepared to be transported to the ED, that's where the first challenge happens. The Narcan makes patients very alert very quickly again, and some will go and some will not go. I understand from several people in the ambulance community that the presence of the police officer is actually very important just for the authority, even though there's no regulation stipulating that, but the police officer saying you will go to the ED leads to significant numbers actually going there. But they don't have to, right? Once they're back up, they're legally competent to make decisions about their own health, even if they're not sensible decisions. So that's challenging. And en route to the hospital, the paramedic can also administer IV or intramuscular Narcan if it's the top qualified paramedic. So if we just put it in a scheme, so what follows is law enforcement is medical. Law enforcement assures the scene, but quite often if law enforcement is the first to arrive on the scene, they will also actually stabilize the victim. Then there's investigating the scene and medical people to transport the victim if they will go. And then we arrive at the ER, where actually also law enforcement detectives will go to the ER and try and speak to the people there, and medical people will also speak to the victim and do a medical check if they are still there. Because obviously if we made this a graph, we would be, at every step, we'd have less victims in the process, if you like. But exactly then what happens is the next question, because that's where a lot of people walk back out of the ER and are difficult to follow. ER, that's the time when there's we call it the golden moment. They're there for, if they got there, they're there for a particular period of time, and that's the time to catch them. Once they're out, then we can't follow them again. I mentioned briefly the Good Samaritan law. So anyone who makes a 911 call, even if they are involved in criminal behavior there themselves, won't be arrested on the scene if that call was made to help the overdose. I've noticed there is some debate about, because it hampers to some extent police activity, but okay, it seems to work. It makes the calls less dangerous for the caller. The availability of Narcan appears to be saving life, but there's also debate about that. Some people feel that Narcan is an enabler in the way that some real addicts see the fact they can actually go to the limit of overdosing because they think they'll know that there's someone who will be around to revive them. That debate we can go on for a very long time, but I suggest we don't do that today because I don't think that helps us in solving the problem. And then the follow-up. So there is 3 major parts of follow-up that I want to mention here. One is drug court. So Lynn was one of the first drug courts in Massachusetts, and we'll talk about that a little later, where essentially if someone is arrested for a drug-related offense, they can get the choice whether they're going to jail or they're going into some sort of rehab program. Of course, a drug court has leverage, so that's if someone is not criminal, that's a lot more complicated. But the judge has the leverage of saying, well, if you don't do that, you're going to jail, so that's the choice. There's also a jail diversion program, which we're going to have someone explain about in a minute. And also there's an upcoming program about recovery coaches. What needs work? This debate, as I just mentioned, I don't think it needs work. I don't think it helps us either way in really coming to a solution for the problem right here. What does need work is how family and loved ones seek intervention. So quite often when people are picked up with an overdose, family wants to do something, and I've heard from several EMTs who are then asked, can they help in getting a Section 35 issued? A Section 35 is essentially where someone can be, against their will, sectioned for their own protection. But of course, that's a civil legal process, and that can't be done by the first responders there. And that chain also needs to be tightened up. And of course, recovery only works when there's motivation with the person. You can bring someone to a recovery clinic, but if they're really not interested, and as happens very regularly, they walk out after 1 or 2 days. And that's what is hard to explain to people in the family who are not using themselves. So the question we need to deal with, and that's one of the ones for the second workshop, is how do we coach non-criminal users towards recovery? There's drug court for criminal users, and there is some leverage to push them towards what we consider to be the right path. But if users are not criminal, that's far more complicated. There's also some challenges in the emergency department. I understand that about 25% of all walk-ins in the emergency department is related to people seeking some form of treatment or detox for drug use, which is a very large number. In Massachusetts, there's a particular regulation where everyone that comes to the emergency department then has to have medical clearance before they can be referred anywhere. That means blood work and urine samples, and that clogs up. That's a big workload for the ED, and it clogs up a lot of that work. But the referrers, the people that they're referred to, won't take them unless that's happened. Many other states, by the way, this regulation does not exist, so that's something that we can definitely look at. And then comes the question, how do we use that golden moment in the emergency department? So again, that's what we're going to deal with in one of the workshops. Then comes the individual approach. How do we work with overdose victims? And I would like to ask Tito Rodriguez, who I now don't see. Yes. Maybe you can come to the front and explain a little bit about what you do, and also Wendy Kent on the upcoming program of recovery coaches.
Well, thanks for the opportunity to represent the Behavioral Health Unit and the Lynn Police Department, and asking us to talk. 2 years ago, the Lynn Police Department applied for a grant, and it's called the Jail Diversion Program, but we become affectionately known as the Behavioral Health Unit. And the grant was to try to assist any individuals who interact with the police department and on a variety of issues: substance abuse, alcohol use, mental health problems, domestic, the litany. But about 50% of what we do deals with opiate addiction. And the grant's been working for 2 years. It was a one-time grant. It was supposed to be up in June in 14 days or so. And through the leadership of the Chief Carpenter and his administrative staff, he's been able to get funds to extend the program for another year. So essentially what we do, particularly from the opiate issue, is we review all the incident reports, and we get notified of the overdoses. And after the law enforcement does what they need to do, what we do is we try to outreach to the individuals and to the families, and see if we can provide any supportive services or any treatment, or make the connection for them. The best description of what we do, for those of you who've been in the military, or for those of you who are old enough to remember a TV series called MASH, we're like triage. We're a MASH unit. People come into us, we try to deal with the crisis and try to get them to what the next step would be. And that's the best description of what we do. We outreach to the person who's in crisis around the issue of his or her opiate use, and we outreach to the families. And we try to meet the person who's dealing with the addiction problem where they're at. Many of the people we meet are in crisis, and they're in crisis around their addiction. And most of them, when we interact with them, they're not ready for treatment. They're just not there. So what we try to do is, for the ones who it's obvious they want to continue to use, we try to tell them where to go to get services, where harm reduction services, naloxone, or where to get trained, what pharmacy to go to. And then we try to sort of edge in, maybe you should consider outpatient therapy, outpatient counseling. We've become very skilled in adapt to trying to get them to backdoor into services. And basically that's what we're doing. Our most effective approach has been working with the families and with the loved ones of the person who's dealing with their addiction.
Good afternoon. My name is Wendy Kent. I work for Project CROAP, which is an affiliate of Bridgewell. Similar to what Tito was talking about, the burning question is always, once someone presents in the ED with an overdose, they get medically cleared, what's the next step? And more often than not, unfortunately, the last thing they want to do is stay there any longer than they have to, and they're usually out the door pretty quickly. And unfortunately, often using again within a short period of time, because when they have been Narcaned and treated in the hospital, they're in withdrawal, they're agitated, they're scared, they're not in a good place. So in an effort to continue to try to close the gaps, Tito and Aaron have done a fabulous job with reaching out to many people, but some people can't be caught up with after they leave. We might get a phone number from them, but it might not be a valid phone number, or they don't stick around in the ED long enough to get the information that's needed. So in an effort to try to close those gaps a little bit more, we have been working very closely with North Shore Community Center on developing a program where we would have recovery coaches on call to the emergency department. And if anybody doesn't know what a recovery coach is, basically these are, it's sort of a step away from a sponsor. Anybody who's familiar with sponsorship in the self-help world, they're available to help individuals who are maybe struggling. Recovery coaches have gone through very specific training. They go through a certified training program, and they are skilled at both meeting the individual where they're at, as well as learning about all the different avenues to treatment. And there are many, and anybody who works in this area knows that there's one size does not fit all. There's many different approaches that can and need to be used. So these individuals will be on call to the ED. We're in the process of recruiting, and in addition to these individuals having gone through a certified training program for recovery coaching, they're also going to go through additional training to work with overdose victims in the ED, because that is a difficult and contentious situation. So we're trying to capture some of those ones that, maybe we can reach out to before they leave the ED, and then, connect them with the BHU or connect them with some kind of case management and try to facilitate treatment placement, or at the very least connect them to harm reduction services if they're not ready to get sober or get treatment. As Tito said, a good chunk of the people that are overdosing are not treatment ready at this time. So we're really having to do some very basic work with them around first steps and moving them towards recovery in the long term.
So one is coordination between programs, because there are many different programs from many different initiators. And also the coordination between law enforcement and health providers. We already talked about that. That's so difficult with all the different privacy regulations. And so the holy grail really here is to get that cooperative approach going for the non-criminal users, to slowly edge them towards recovery in a way that makes it possibly successful. Then comes prevention. How to avoid usage at all. One of the activities in Lynn is that the police has a school resource officer in every middle school. It's a uniformed police officer full-time in the school, who does many different things, but one of the things that they do is to teach an anti-opiate and an anti-marijuana curriculum. And they're also involved in a number of programs that run in these schools. One is called All Stars program, essentially where the school identifies at-risk kids, and where through engagement, through activities and working together, these school resource officers try and get a good gauge of what the risks are, and take from there maybe further action to try and mitigate those risks. So that's what happens from the police point of view in those schools. And those four people are funded for the foreseeable future, from what I understand. Next to that, the public schools also teach a health curriculum, and part of that health curriculum are classes about addiction, about opioid use. So for example, and I'm not going to read all of these out, but grades 6 to 7 and grades 7 to 8, and then there's the next slide, grade 8, 9, and 9, 10. But so this is middle school and the beginning of high school. So let's pick the one on the left, for example. In that curriculum is covered what self-image is, self-improvement, myths and reality, so just fact, what is fact and what is not fact about marijuana and smoking and alcohol. How to deal with anger, how to deal with advertising, how can you be assertive to try and not have to submit to peer pressure, those kind of things. And as the age goes up, if you go to the next slide, you'll see that, for example, in grade 9 and 10, it's more about valuing and decision-making for good health. So it's more about taking personal responsibility for not doing those things. Family communications, healthy relationships. So Lynn already has a program that stretches 4 grades, essentially, to deal with this. But it is a program that's part of the regular health curriculum, and so it has a limited amount of time. It's a 2-week program, from what I understand. It's about 10 2-hour classes. So it's good, but it's still relatively limited. There's an interesting example in the state of Ohio, which you saw earlier on the map, also has very serious fentanyl issues, where they actually started kindergarten. So there's a much wider age group, and it's kindergarten, and I believe it goes up to grade 12. But maybe you can go back to the kindergarten one, where it really, so this is for kids 5, 6, 7 years of age. It teaches them about differences among food, what poisons are, what medicines, drugs are, to understand what it means if there's still a vial with some pills in a medicine cabinet somewhere. Very, very basic stuff. And then it slowly goes into it's kind of the same subjects that we saw in the Lynn program. And as they get older, in high school classes, even review of addiction, how do you deal with medication? Because that actually, you saw the average age was 21, right, of the first opioid use, because that's the average age. So there's also quite a few at 15, 16. People with sports injuries might be prescribed certain drugs. People might use it recreationally. So that's also the time to get it. But if you start in high school, you're too late. So it needs to start earlier. So Lynn already started 6th grade, but there are other examples where they started kindergarten, and then as part of a much larger program. What needs work? So the interesting question here is whether that health curriculum could be somehow integrated into the regular curriculum. So for it not to be 2 hours after, as part of a normal school day, but 2 hours of a health class, which I was a pretty difficult adolescent, I think would have been pretty low on my list of priorities too, because I'm sure there was no grade that counted for me progressing to the next year, to how to somehow integrate it in the regular curriculum. Could it be a part of biology classes? Could it be a part of geography classes? Could it be a part of even poetry classes I've heard mentioned in an example? That's one challenge, and there's a group, one of the groups has this specific question to deal with. How can we do that? The other question that is really important here is, again, going back to average age 21. So people, we get to them at school, and then they're relatively easy to find, right? They're in groups, they're in a specific location, they're there ready to listen to whatever we've got to tell them. Then what happens at 18? Some people go on to college, they could still be found relatively easily, but some go on to work, and then it disperses. And in that period between 18 and 21, that's the time when the risks associated with becoming opioid users are so prevalent. So that's something else we have to find a solution. How do we get to those people if they're not easily accessible in a school, in a classroom, in a college, or somewhere else? And then comes the interesting question, how to approach opioid use with a healthy perspective. It seems that the approach of just saying no doesn't work, at least for the group that has the propensity to want to use this, these kind of things. There's a large discussion about stigma and not stigma. I was told by someone, I think it was someone from the police, who had an interesting comment saying, we've managed over the last 15 years to attach quite a big stigma to smoking, which seems to have had an effect on less uptake on smoking. Now we stand in the kind of around the corner with sneaking a cigarette. Well, on the one hand, it's good to reduce the stigma around opioid use so it can be discussed and therefore be treated. It's an interesting fact, but how do we make clear that this is not a smart thing to do and this is not a regular activity while not having that stigma? That's a challenge that we somehow have to tackle, I think. That was on the prevention side. Then comes the outreach side. So how do people get support? And we have two work groups later. One is on outreach for the community, and particularly a focus on how can we get the business community more involved, and another on how can we get outreach done to professionals. So many of you here are first line, what I would call first line professionals, your health providers, law enforcement officers. You deal with these issues every day as a major part of your job. But there are also a lot of professionals that will get to deal with this from time to time. A school teacher may or may not get to deal with this on a regular basis. A family health practice may or may not get to deal with this on a regular basis. So this is kind of second line of professionals for whom this is not priority number one, but it will crop up, and they could have significant influence on getting people towards the right services. One of those outreach efforts is harm reduction, and I would like to ask Mary Wheeler of the Healthy Streets program if you would like to say a few words about that. Pretty much in the vein. You can stand, sit, whichever you prefer. But I'm handing you the microphone.
Good afternoon. My name is Mary. I run the Healthy Streets Outreach Program at Lynn. Excuse me. We are DPH funded as well as BSAS funded to provide outreach education, HIV, hepatitis C prevention education to injection drug users and their families, as well as naloxone distribution across the county, give or take, Essex County. We're also involved in overdose follow-up projects with Chelsea, Saugus, Swampscott, and soon to start with PBD Fire Department doing overdose follow-ups about resources, treatment, and naloxone distribution. So a harm reduction program, we meet people along their spectrum, whether it's meeting folks that are in chaotic substance use, they're living in the streets, all the way up to long-term abstinence, helping folks with their resumes, closing their quarries, finding places that will accept them for hire, having a criminal record, and kind of everybody else's situation in between. And this program, there's the folks that started it are in the room, and it's been in this city since 1991. So,
other examples that we need are really sort of this early detection from that second line of professionals, right? Not people who are involved in dealing with drug addiction and detox programs and drug counseling, but the people that would deal with families on a regular basis. So we mentioned already schools are now required to verbally screen students. Schools run programs for at-risk children, but and there's been training for school nurses, teachers, guidance counselors, etc. But that training needs to keep going to make sure that they're the first ones to detect and then find the right places to go. An interesting aspect is that businesses so far have been involved relatively remotely. Most businesses who have a public function are very clear if they have a user on their doorstep that they want them gone, and I understand that because that will scare the customers away like nothing else will. But the business community so far hasn't been involved on a very active basis. The non-profit community in Lynn has recently had some initiatives, and I would like to ask Kathleen to say something about that.
So after many conversations about what can we do if there's no money, how can we help if the size of the problem is so overwhelming, we together at our, I don't know what it is, Mass Overdose and Addiction Prevention, I don't know, I call it the task force. After a collaborative task force of us sat around and said, well, what can we do? It was Dr. Kelly Holland at Lynn Community Health Center who suggested that we nominate a champion, that each of our businesses, each of our nonprofits could nominate a champion to come learn the basics of substance use disorder and learn how to use Narcan, because we know that the research proves that where there is more Narcan, there are more lives saved and more opportunities for recovery. So we put out, all hands on deck email, first to the nonprofit community, and offered our first training this week. And so there was about 8 nonprofits serving everyone from preschoolers to elderly citizens. And everyone there learned how to use Narcan, the nasal spray overdose reversal drug. Really simple. And we were all sent back to our organizations to decide, where would we keep this? Do you keep it with your first aid kit? Do you keep it with a defibrillator? Do you have someone on hand who knows where it is and if you need to use it and when and how and what are the signs of an overdose, those kinds of things. So simple. But every single one of us, all of our organizations, have people coming in from the public who are coming into our offices, to our counters for assistance, picking up their children at daycare. There's no reason to think that any one of them or our coworkers, anybody, might be in a situation where one of us might need to save their life. I wouldn't even, I bet so many people in this room know CPR. CPR does not solve heart disease. It only keeps a heart beating. And Narcan is very similar that way. It keeps a person alive so that they then have an opportunity. And why wouldn't we put that in the same category? So that every single one of us, so you don't have to be an EMT, you can be a librarian and have Narcan on hand. And it may be, someone who is very beloved to someone else that you save. So we started with 8 nonprofits. We are going to offer it again. We are going to be knocking on the chamber's door and hoping that that our business owners, HR directors, CEOs will also be willing to know how Narcan works and keep it on hand. And that was just a tiny little brainstorm of something that costs very little that may have an enormous impact. And I'm hoping that in our breakout sessions today, we'll have maybe some more ideas that are similar to that.
Don't go away. Kathleen has 2 hats on today. Another outreach program is the Learn to Cope program, and this is really a self-help program, so of which you are part, right? So that.
Learn to Cope is a family support group, peer-led, and it is a support group for parents and loved ones of people who are suffering with substance use disorder. It was actually formed in 2004 by Joanne Peterson and has grown, sadly, although we're grateful, grown to about 24 chapters all across Massachusetts and in a few other states. The chapter that is closest to us is in Salem at North Shore Medical Center. Every Thursday night, there's about anywhere between 40 to 80 parents who come and are able to offer and gain resources from each other, education, have access to hearing the stories of people who are in recovery and experts who are in the field of recovery. And it's a beautiful, magical place if you are feeling like your family is alone in this, because this is a group that offers profound amounts of hope to each other, because this disease, this epidemic, is there's hope on the other side. People do recover. And so we support each other in finding ways to support ourselves as we deal with the impact of our loved ones' addictions. In my case, that is my 21-year-old stepson, who has a year and 4 months of sobriety under his belt. And so we have been through that process of 2 years ago, when we first heard the word heroin. We had heard a few words before that throughout high school and dealt with that like you might deal with a reckless teenager. And then you hear the word heroin. This was the same week that the Governor Deval Patrick declared an epidemic in Massachusetts. So the amount of information that was available to us about 4 or 5 days before that happened was none. So we looked at each other and said, my husband and I, we can't call the police, right? They'll arrest him. And then we said, we can't call a pediatrician. What the heck does a pediatrician know about heroin? And then we said, we can't call the guidance counselor. You know, they'll think he's a drug addict. He is. But That was 2 years ago. I'd like to think that 2 years hence, that we might have known where to go for help because there's been so much publicity in the last 2 years. Although I continue to meet people who have no idea where to turn. For those people, I would say that Learn to Cope is a game changer. You will be surrounded by love and hope and education and resources for yourselves and for your loved one. It is learn with the numeral 2, cope.org. And you can look up chapters anywhere. We meet on Thursday nights at Salem Hospital, and it's a beautiful experience.
So I'm Ricky Lopez. I'm the drug court coordinator for Lynn District Court. I work with Judge Lamothe. And I came on in a grant-funded position last May, so it's just been over a year now to assist the team with finding treatment programs for our clients, as well as updating the screening process that we have for potential clients. So the meeting that was just mentioned, we have our drug court session on Wednesdays from 12 to about 1:30. Before that, from 10:30 to 12, we have a lot of folks, the staff meet and do a briefing of what's to come in the session. So we have the probation officer, myself, the Judge Lamothe, defense attorneys of the clients that we have appearing that day, as well as treatment providers in the community. So we typically have a range of folks that have come. We've had people from Project Hope, the Ryan House, Lynn Community Health Center, Meridian House in East Boston. Unfortunately, folks can't come every week because, as we all know, this is tight schedules that we're working with, but we appreciate our treatment providers coming immensely. They're there to offer advice and assistance, not just on any particular client, but to offer advice for clients that they've never met. So it's very helpful. And we discuss what we're looking at with certain clients, if they're doing well, if they're not doing well, how do we fix that? How can we amend their treatment plan? What resources are available to them and that we can help them to put in place. And as what was mentioned earlier, we do have some recovery coaches from the town of Saugus who come to our meetings as well. So they're able to offer direct assistance, like Wendy was saying, a mentor. And it's been a great collaboration that we've had. I also want to quickly mention that we take drug court referrals from anywhere. It's not just within probation. If you are a treatment provider, if you're working with Lynn Police, really anywhere, we're happy to get a phone call if you have a suggestion of somebody that could benefit. Now the person has to have legal cases, of course, open, but besides that, we could find a way to make that work. So those clients that you see that you feel like may never get sober or they're impossible to reach, those are the clients that we would love. So please let us know if you see any of those clients.
Hi, everyone. Good afternoon, and thank you all for being here, and thank you, Mayor, for hosting this event today. I want to give you a little insight as to where we've been and where we're going and where the funding's at, so that when you break out in your discussion groups this afternoon, you'll know what's currently happening and what's not happening. Little quick history and background. I promise I'll be brief. But just so you know, I started working as the Director of Health in 2004. And started going around visiting social service agencies and trying to figure out what the public health problems were that were going on in the city. I met with Mark Kennard, who at that time talked about the Oxycontin explosion. And the delegation at the time was Senator McGee, Representative Walsh, Representative Fentanyl. They had been talking at the Lynn YMCA with the police chief and stuff about what they were seeing with this Oxycontin explosion going on. Soon after that, I found myself testifying in front of the Oxycontin Commission. And during that testimony, I sat there and I listened to mom after mom get up there and tell their stories about the young, beautiful sons and kids who became addicted to this drug and how their lives had changed. And I was sitting there, half a brain of a mom and half a brain of a health director, thinking, oh my God, my son's 7 years old. And by the time he hits middle school or high school, this thing could really explode. And I thought, oh my God, this is really bad. This is going to be really bad. And unfortunately, I was right. It did explode. My son, so far, so good. But for the grace of God, right? Go on. He's 19 now. But because of that testimony, because of the OxyContin Commission, we got AG funding. Purdue Pharma was actually giving out, I think they were trying to make amends for what they had done with the OxyContins. They were giving out grants. And through the funding that we were able to get during that time period, we created what was known as the Communities That Care Coalition. Communities That Care Coalition was a substance abuse coalition made up of schools, nonprofits, social service agencies, coming together and looking at the issue of substance abuse. Because we had that coalition, because the Communities That Care existed, we then set ourselves up in a nice way for ongoing funding from DPH and the Bureau of Substance Abuse Services. So that coalition and that background is really key to where we're at today. So MOAPC. There are actually 3 prevention initiatives currently going on in Lynn, all separate. MOAPC is the Massachusetts Opioid Abuse Prevention Collaborative. And what that is it originally began as mass call funding, which I'll explain. But when you see collaborative, we've been asked to go out and regionalize some of the efforts that we've done in the past. Unfortunately, there isn't a lot of resources available in the state, so they've asked us to take the resources we have and kind of mentor other communities around us. So the collaboration we have with MOAPC is actually with Salem and Peabody. The Substance Abuse Prevention Collaborative, SAPSI, is a fairly new funding, came off of last year, off a former grant. And the Partnership for Success, same thing, is a new funding from the last year, and that came from a former grant as well. It's a collaborative. The collaborative we have with SAPSI is actually with Salem, Swampscott, Marblehead. So the 2 that say awaiting plan approval is because when you get this funding, the first year is really a lot of needs assessment, data collection, trying to see what the landscape is out there. And we just submitted our strategic plans to the Department of Public Health and hoping for approval on those so we can get moving into implementation next year. I have to put my glasses on to see the screen, but I have to take them off to read, so I'm sorry. Okay. So, Mass Call 2 started in 2008, and that funding was strictly for the prevention of overdoses, both fatal and non-fatal. And all of this funding is really for policy, practice, and systems change. There's no funding here for programs or for services. This is really at us looking for data-driven exercises that we can do, strategies that we can do that really will impact the way things are done, either through policy change, systems change, or practice changes. MOAPC, which started in 2013, expanded into actually being able to look at prevention of use. So with Mass Call, we were strictly looking at prevention of overdoses. MOAPC allowed us to look at prevention of overdoses and prevention of use. And again, like I said, we had to expand our efforts and to mentor, I should say, Salem and Peabody as well. So Mass Call 2, we started looking at a variety of initiatives to prevent overdoses. We did education for those at risk of overdose, tried to look at reducing barriers to calling 911. We did some education, substance abuse, addiction education with the Lynn Police Department, safer prescribing practices. We did prescription monitoring program education with North Shore Medical Center physicians. We did start the prescription drug take-back program, which is a 24/7 drop box at the Lynn Police Station where you can empty out your medicine cabinet before someone else does. And we started looking at increasing access to Narcan wherever we could get it, basically into the hands of family members and individuals. Okay. MOAPC now, our current focus is again mentoring and engaging Salem and Peabody. So we've had some success very recently in Salem and Peabody. They are now, their first responders are now carrying Narcan. They weren't in the past, and now they are. Our first responders, our police have been doing this for almost 2 years now, carrying Narcan. Developing and enhancing post-overdose care. You heard about the Recovery Coach program and trying to reach those who have suffered an overdose. Developing a centralized database. We've talked about that today. We're going to be doing more work on that. So really using the data to inform our strategies. Policy changes regarding opioid practices in the medical community. The increase of Narcan, we've tried to get that into different segments now. We've done trainings with the Lynn City Council, with the Lynn Board of Health, at City Hall, at the library, where we did have our first overdose at the end of May in the library. And we've been trying to do some promotion with some of the business owners, some of the restaurant owners. We've had a couple of overdoses in bathrooms of local restaurants and such, so we're trying to increase awareness there and get some Narcan out in the community as well. And working with the school system, as always, in prevention and early intervention. And trying to identify, one of the discussions we've had with the school department is really trying to identify youth at risk, but like you said, you saw the ages of the folks who are engaged in this problem, and they have kids. And so are there kids in these homes that are witnessing overdoses or living with a mom and dad who's addicted? And how do we draw that loop back and get to those kids and offer them assistance as well?